Right, so it's officially 12:01 on my clock, so I can say good afternoon to you all here. And firstly, we would like to thank you for joining us and taking time out of your day to join the webinar here. So before we kick off proceedings, I just want to take the opportunity to mention the Healthcare Infection Society's annual conference, which is taking place next Tuesday and Wednesday in London. And it's a fantastic lineup, and Dame Judith Hackett will be the keynote speaker. So for those of you who have signed up, we look forward to seeing you next week. And for those of you who haven't, there are spaces available with a QR code there in the right-hand corner with an option to attend either or both days. So definitely worth looking into that for those of you who haven't already logged in. The next slide. In addition to that, we've also provided a link here to the resources provided by the Healthcare Infection Society with their MRSA guidelines, which are the joint guidelines with IPS, our podcast, and then our special edition, which we will speak about today as well. So today, this webinar is brought to you by IPC Partners in collaboration with the Healthcare Infection Society. My name is Siobháin Kelly, and I'll be chairing the session today. For those of you who have attended an IPC Partners Journal Club previously, you will likely recognise the two men on screen here today, Dr Phil Norville and Dr Jon Otter, and I will let them introduce themselves shortly. I myself am a clinical microbiology registrar in Dublin and the current Graham Ayler Fellow with the Healthcare Infection Society, just to give a bit of context. And as part of that fellowship, I'm a trainee editor with the Society's affiliated journals, the Journal of Hospital Infection and Infection Prevention and Practice. And in March, we published a special issue on MRSA. So I'll now hand you over to my colleagues so they can introduce themselves before we briefly discuss the edition and we review the two selected papers as well.
Who's going to go first, Phil?
You
go first. Oh,
okay.
Go on, you go.
Yeah, hi everybody. As Siobháin said, my name's Phil. My day-to-day job is I manage the Infection Prevention Control Service at Oxford University Hospitals. I started as a PhD microbiologist, working on MRSA actually, which is one of the reasons I'm so interested in the journal collection and excited to be here today. And one half of IPC Partners with Jon. I'm really interested in all kinds of IPC interventions to try and reduce the transmission of all infections, but particularly MRSA. So really excited to be here today. Jon.
Yeah, hi everyone. Good afternoon. My name is Jon. I'm the director of IPC at Guy's and Tommy's, also a researcher at Imperial College London. Fun fact, Phil and I did our PhDs in MRSA at exactly the same time in different labs in different countries, and didn't even cross paths until later on in our careers. Do you know what? I've actually got a question for you, Siobháin, and for Phil. I know I'm breaking convention now, but when I was looking for this lovely virtual background for today, I wondered, when is the last time you actually looked down a microscope at the lovely purple bunch of grapes? Siobháin, you're going to say yesterday, aren't you?
Well, it's actually been somewhat recent, having just completed the Part 2 exam. So nice. With that, there's a good bit of lab exposure expected and practice as well. So I have actually seen it somewhat recently, yes. You'll
been ages.
Hopefully glad to hear.
Yeah. Been ages for me, unfortunately. Although I do have some electron microscopy from my PhD framed as a bit of a memory to my PhD, so I do see that regularly.
Nice. And for me, it's a very long time ago because my postdoc was all molecular. I don't think I looked down a microscope once, so it'd be 10 years for me before I had my hands on a microscope. All right, back to you, Siobháin.
Great. So we've the opportunity here, thanks to Jon, to see it all recently. So really just to give some context again with the special edition that we had and collection is, I suppose the journals receive a diverse range of manuscripts from around the world on a variety of topics, and we had noticed that MRSA emerging as a theme in the period before we collected the special edition. And I suppose whilst MRSA may no longer be considered the formidable threat it once was, and perhaps in part due to the emergence and rise of other MDROs, CP and Candizyma aureus, it does continue to cause significant morbidity and mortality, and therefore it felt appropriate and timely to keep spotlight on our aptly named enduring foe. So today we're going to discuss two papers from the special edition, one which featured in the Journal of Hospital Infection and the other which featured in Infection Prevention in Practice, and we will have a Q&A after each session. So before I hand you over to Phil, I would like to remind you some housekeeping rules. So we would encourage everyone to actively participate. We will be monitoring the chat, so please feel free to share any questions and we address those after each paper. And we will discuss the 2 papers of the Q&A after each. And just to note that this session is being recorded and will be made available on the IPC partner platform. So without further ado, Phil, I think you're going to take the reins.
Thanks, Siobháin. And just finally, before we get into the actual paper itself, we run a regular journal club through IPC Partners, and this is just giving you some of our aims. So we're ultimately here to try and discuss a topical IPC published paper, and we're delighted to partner with the Healthcare Infection Society on their collection. And really, as Siobháin said, it's all about interaction and discussion. John and I aren't going to speak for that long about the paper, because actually what we've found is that the really rich discussion comes from your questions and your Q&A afterwards. We'd like to think we're building a bit of a network of enthusiasts as well, and we don't take ourselves too seriously, so we like to try and have a little bit of fun as well. So if you have comments and questions, use the Q&A for questions for John and I directly, or you can use the chat to share your experience as well. Okay, thank you, Siobháin and John. So my paper was looking at the prevalence of both MRSA and VRSA, which I haven't said out loud for a while, actually. Doesn't roll off the tongue as well as MRSA does. And looking at those risk-associated factors with patients with wound infection from this area in Ethiopia, which is part of this collection that we're talking about today and published quite recently in Infection Prevention and Practice. So my first point I stole from John, which John wrote in one of his blogs, is that, you know, MRSA, as Siobháin alluded to, it isn't the foe that it once was, but it's still very relevant and topical from a global health perspective. And certainly within my organisation, we have challenges around the management of patients with MRSA. And I was really interested to see about the prevalence in a less economically developed country. So looking at the prevalence in Ethiopia was really interesting. And also I think that we talk about MRSA quite frequently, but what about VRSA and that vancomycin-resistant element? Also, I've been aware from my own kind of studies and research that we do see really high prevalence in areas which are less economically developed, like Africa. So I was really interested to see about the prevalence and looking to see, you know, in a less economically developed country, what their methods were and how they went about conducting this study. And as well, you know, having my background working on MRSA as well, it was something that I'm quite interested and still very passionate about. So the study was undertaken at Nakanete Specialised Hospital, which is in Western Ethiopia. And what they did was they used, over a 6-month period, they were taking swabs from patients who were presenting at the hospital with an active wound infection. And they had 384 patients who they took wound swabs from. And essentially they were taking those wound swabs and then putting them onto this specialised chromogenic agar to be able to accurately identify the presence of Staph aureus and then go on and quantify whether or not MRSA or VRSA was present using that chromogenic agar. And then they also looked at looking around some antibiotic susceptibility to various antibiotics using a disc diffusion method. This is where you place the antibiotic impregnated discs into an agar, and then you look, or on the surface of the agar, and you look for the zone of inhibition around it to see whether or not the organism is resistant or sensitive. Their key findings from the study, the vast majority of the wounds that were analysed were deep wounds, and the majority of infections were on the limbs, so in places like legs, feet and hands. They isolated almost 30% of Staph aureus from the wounds of those patients who had the active wound infection. And this is the first bit which really staggered me, is that just look how low the prevalence of isolates that were sensitive to all the antibiotics tested were, 6.4%. So a really significant proportion of all the Staph aureus that they were detecting in these wounds having resistance to at least one antibiotic. And I've got a figure in a couple of slides' time which will show you just how prevalent some of the resistance in some of these isolates were. Then this is probably one of the most interesting findings from my perspective, looking at the prevalence of MRSA and VRSA. 40% of the isolates of Staph aureus were methicillin resistant, and just 7% for vancomycin. I think when I went and did a little bit of digging, Those prevalence rates are a little bit higher than what we might expect to observe here in the UK, particularly around the VRSA. So I think that we tend to see maybe somewhere in between 2 or 4%, depending on what literature you look at. And then out of those MRSA isolates, they went and looked a little bit further at their antimicrobial susceptibility profile, and a huge proportion of them showed multi-drug resistance, so where they were resistant to multiple antibiotics. And as I was reading this, it starts to throw up key questions around what are the treatment options for these people with these wound infections, given such a high degree of antimicrobial resistance. This is a chart that I've taken directly from the paper, so huge amount of information here, but it's essentially showing you the percentage of isolates that were resistant to a whole panel of different antibiotics which had been tested. And if you just look, the S is sensitive, the I is intermediate, and R is resistant. If you just focus on the R column, you can just see the proportion of the organisms and their resistance. So a huge proportion, as you'd expect, of MRSA was detected. So you've got a high level of penicillin resistance detected there in the Staph aureus. But if you look at the MRSA on the right-hand side, you can just see there how there is really high levels of resistance to lots of different antibiotics, with all 100% in some cases being resistant to the antibiotics tested, but then really some high indications as well for things like ciprofloxacin and also gentamicin and tetracycline. So again, just starting to build a picture about how resistant some of these isolates are to a whole range of different classes of antibiotics, including, the ones that we traditionally associate our beta-lactams with MRSA. So a high proportion showing multi-drug resistance, which we've talked about, and this is just a bit of more information around the different antibiotics that were seen to have resistance for. The next interesting thing was looking at the kind of factors that were associated with the prevalence of MRSA. And I guess, as you'd expect, age, sex, education level, and marital status weren't predictors for the prevalence of MRSA. I think maybe the only one I'm not maybe a little bit interested about in digging into a bit more detail is age, and whether or not how that wasn't a factor in this case. But the things that then we look at which were actually associated with a higher prevalence of MRSA, the depth of the wound, the history of wound infection, history of antibiotic use, are three key factors. And I think all of those really, if you think about it from a kind of clinician's perspective or an infection control perspective, they start to make a lot of sense, don't they? If people have had a wound infection previously, it might have allowed the development of another infection or a predisposition to having an antimicrobial resistant organism. And obviously this history of antibiotic use as well, potentially being a key factor in the presence of antimicrobial resistant Staph aureus or MRSA and VRSA in the wound. So in terms of what that means and the points for discussion, the authors reported that this kind of prevalence of Staph aureus wound infection is consistent when they compared it with similar geographical regions, but actually lower than the pooled national prevalence. So if you're looking at Africa as a whole, their prevalence was slightly lower. As I've said previously, the rates of wound infection with Staph aureus seem to be quite comparable with data that we have here in the UK. However, I think that the high prevalence that they observed of the multi-drug resistance in the MRSA isolates is quite concerning. I also had a question really about the correct method for both detecting VRSA and also looking at like the antimicrobial susceptibility profile. We know that this diffusion isn't recommended by the CDC. So, what are the correct methods to be looking at determining the resistance to vancomycin? And I think the thing that I didn't see within this paper, and I admit it's only talking about potentially prevalence, but I would really interested to see what the follow-up for these patients were. So what were those treatment options that were given to those patients with the wound infections who had these multi-drug resistant isolates of Staph aureus or MRSA and VRSA? I always like to think about infection prevention and control, as being all about the prevention. We know we're running out of treatment options in the light of antimicrobial resistance. So trying to think about, if we're having a lot of these patients coming with a high prevalence of Staph aureus infection in their wounds, how can we prevent that wound infection taking place? This study wasn't limited to just people who had surgery. It was also talking about wound infections from people who'd been in maybe accidents and had wounds that way. But if we think about when we're in control of some of these patients, how can we think about potentially screening and then decolonization of Staph aureus to potentially prevent wound infection that way? The other thing that was really kind of jumped out to me within this paper was just the prevalence of MRSA rates in some of the other areas of Africa. 86% in one of the studies referenced was the prevalence rate of MRSA in a similar study from Nigeria. The other thing to point out again, which we've already talked about, is that their prevalence of MRSA in this in this particular study was higher than other studies in the region. And I think as well, we need to consider what these results mean in the context of antimicrobial resistance and the global AMR pandemic. So what does all this mean for IPC? I think this paper is a really interesting study to look at, the prevalence of Staph aureus, and it is really highly prevalent in these wound infections in this particular population. Really interesting as well to see just how high the level of resistance to some of the antimicrobials is. In terms of the risk factors, though, that I think this study highlights and is really interesting, we talked about earlier about the depth of the wound, previous wound infection and antibiotic treatment being significantly associated with MRSA. So we need to think about that when we're thinking about looking at our patients, if they're coming in maybe for surgery again, for example, or we're kind of seeing them in other settings. And as well, I think this study really highlights that given the antimicrobial profiles of the Staph aureus isolates that have been assessed, we need to think more about prevention because we are essentially running out of treatment options. And I think this study just shows just how widespread the AMR pandemic can be when you've got so limited treatment options due to multi-drug resistance. And I think this kind of falls into my final point, is that I think this study has kind of an important link to the global AMR considerations that we are facing within not just the UK, but globally. We are seeing that we are running out of treatment options because of this multi-drug resistance. So how can we ensure that infection prevention control comes to the fore and actually talks more about the prevention of these infections in the first place? Because we know that when we can prevent infections, we can reduce the need for unnecessary exposure to antibiotics, and then kind of reduce the opportunity for these organisms to develop resistance to antimicrobials. Okay, I'm going to stop there and I'm going to hand back to Siobháin to take us through the Q&A.
Great, thank you, Phil, for your excellent summary. So we've had a few comments during your presentation there, and we have Georgina here, who's recalled her first MRSA, so days before we had our MALDI and all our other equipment, identifying that in a thermonucleus. And then we spoke, and which you touched on as well, Phil, about VRSA. So I know they did use disc diffusion here, and then UCAS guidelines then are for broth microdilution. So I suppose how accurate those results are, it is hard to know, but it is definitely concerning there to see the levels of actual multi-drug resistance within the isolates as well. I suppose one thing I was interested, and we don't have available to us, is possibly the standard of care these patients actually receive. So are swabs something that they would routinely receive or have taken, so that we would actually have some microbiology results to help guide treatment? And what are their empiric options or preferred treatment? And based on the fact that we have quite multi-drug resistance, you would wonder about indiscriminate use of antibiotics across the board for these patients, which obviously is just increasing the drug resistance of these isolates as well. So with this, I know, I said that the drug resistance is hugely concerning, and I suppose any take-homes that you had from this, or any learning points that we could take from this, granted that we have a different system, that we have greater access to microbiology, we have greater access to treatments, But I suppose going forward, anything that we can take from this in the way of learning then from these patients.
I think, it probably highlights for me the importance of infection prevention control. I think that it's a really interesting study because it's able to just look at the prevalence and I think highlight firsthand just how widespread antibiotic resistance is in some of these isolates. So I think that, it's a really interesting study to be able to look at that prevalence rate and then make us think a little bit more about how we can kind of try and reduce the impact of this further down the line. We've seen, this explosion of antimicrobial resistance because of potential overuse or inappropriate use of antibiotics. So we now, I think, gives us really good evidence that we need to be more prudent. And I think that the message is getting out there. We're seeing more and more public awareness campaigns. We're seeing organisations like the World Health Organization, the Infection Prevention Society in the UK and HIS talk about AMR more frequently and try and educate not just our healthcare professionals, our doctors, our clinicians, physicians, but actually the public. That we need to be thinking more prudently around, going to the GP and asking for antibiotics. So I think in terms of learning, for me, it's talking about maybe this more kind of awareness of AMR. And I think, there's also some considerations to look at, like we've talked about previously, maybe some of the things to consider around the patients in this situation and how this infection has actually developed. Is it being due to, failings in care? Or is it just because they've, it's down to kind of environmental exposure and thinking about how we can prevent that exposure in the first place?
And one interesting thing as well is from the paper, although they had given the susceptibility patterns for the MRSA profiles, they didn't give the equivalent for VRSA. So I was interested to think of what treatment options they may have available, because we're fortunate in that we've access to daptomycin and linezolid, but I do wonder what options they would have to actually treat a VRSA infection, given the cost and how available these are in these parts of the world as well. So also another concern about how treatable they are in these settings.
Siobháin, can I throw in a question? Do you mind? Phil, do you have a sense of where these patients were acquiring their MRSA? Because the proportion of methicillin resistance amongst Staph aureus at 40% is high. It's at the very high end of what we'd see in Europe, a lot higher than we'd see in this country. Do we have a sense of whether these were hospital acquired or hospital associated, or whether there's a huge issue around community associated MRSA in Ethiopia, or in this region anyway?
It's a really good question, and I think we can't quite answer it because the patients were coming in, with these wounds, which they developed the infections in following different preceding histories. So some of them had actually been patients that had been admitted into hospital. Some of them have been developed infections, in these wounds after they've been maybe in a trauma like a car accident. So difficult to know where the MRSA is coming from. I'm assuming that it's probably quite diverse, given that you've got patients in, various different settings where they've actually developed the wound from, if that makes sense.
I know we've a comment here as well about VRSA prevalence among Staph aureus strains in the UK. I think you mentioned it was 2 to 3%. I couldn't comment on Irish data or set myself, but thankfully Ralph here hasn't seen a case yet in the north of England. So perhaps another part of England is seeing a high level of those. So that was, they were just wondering, is there a trend on the rise in the UK, or whether any of you have any knowledge of this, whether we're seeing more VRSA than previously? Or
I can come in on that. I mean, I think this opens up a whole question about what we mean by VRSA. I think maybe 2 to 3% of Staph aureus or MRSA in this country have some level of reduced susceptibility to vancomycin. Yeah. But to call that VRSA, I'm very skeptical about those figures for a UK setting. As skeptical as I am about 9% or whatever it was, 7% in this country, I'd be astounded if those isolates truly were VRSA as measured by broth microdilution. So I think there's a big overestimate of vancomycin resistance. There may be something much more subtle around reduced susceptibility with the visas kind of creeping MICs.
Yeah, and whether we just wouldn't actually use them vancomycin clinically, about concern about clinical response perhaps in reduced susceptibility to vancomycin. So yes, I know you mentioned, John, about that I've asked about where these MRSAs are coming, and as Phil said, it seemed to be a diverse range of patients, and I think gunshot was actually one subsection as well. So probably things we're not seeing to the same extent in this part of the world, thankfully, that they are some of the wounds that were responsible. I suppose with MRSA, and I suppose that the big concern is without this microbiology, ability to treat patients, ongoing unnecessary antibiotics, inappropriate antibiotics, really a vicious circle there. So shows, I suppose, the importance of actually having the microbiology to help guide treatment and the susceptibility patterns or panel.
Yeah, I completely agree. And I think that, when you've got something as serious as this going on within the patient, then making sure you make the correct decision around the antibiotic that's prescribed is really important, isn't it? Because you want to make sure that these patients get better as soon as possible. And I think that given in some of them you might have very limited treatment options, then it's important that you make the right decision the first time round.
With some comments here just about key risks, including history of previous infection and antibiotic exposure. So, asking if a lot of these are healthcare associated, probably hard to fully discriminate between those data sets on the study as well, and asking if we know why disk diffusion was used for vancomycin, or sorry, why is disk diffusion tested for vancomycin still practiced, and not just E-test or MIC. And we do know obviously that UCAST recommend the broth microdilution, so I'd expect that's probably based on resources and what is available in certain settings.
Yeah, I think it links to a question that Fernanda was asked, talking about maybe this overestimation, which John alluded to around VRSA. The methodology for testing it is extremely important, isn't it? I wasn't aware of identifying the rationale for why they were using that particular method, but I would assume in maybe a less economically developed country, it might be down to resource or expertise. I mean, I'm trying to think that if I was working in a laboratory, is a disk diffusion a little bit easier? It probably is, because you've just got to kind of do that one step as opposed to the multiple steps within a broth dilution.
And I suppose regardless of potentially maybe not being fully accurate data on the VRSA, but it's always helpful to have research from these lower income countries and developing countries, because we don't have the surveillance that we're accustomed to, and as a result there is a paucity of data there. So it is always good to highlight this research when it is available, to see prevalence in other settings as well.
Definitely. Siobháin, can I just pick up on this comment about risk factors for MRSA? Because I was really surprised actually by that little outcome. As Phil noted as he went through the slides, that age wasn't associated as a factor for MRSA.
Yeah.
Pretty much every risk factor study I've ever seen, age seems to come out as associated with MRSA.
Yeah, and I had seen there's quite a significant portion of actually younger patients who were in the study, which I was also surprised at. And again, I suppose difficult without actually being able to delve further into their prior risk factors as well. So we know age as well, but that isn't independent of, we don't know if those patients are very comorbid in other settings, have other significant risk factors. Younger patients having other significant risk factors as well. Yes, I was surprised at that, and I would wonder about other comorbidities in the background for potentially those younger patients being responsible for.
Agreed, and to the point in the chat there that the demographics are different in Africa, and I'm unaware of the demographics, but it piqued my interest because when community MRSA, the USA 300s, were emerging in the US, one of the first kind of sentinel markers of that was the typical association with MRSA and age seemed to change, and they began to see younger patients appearing in the ED with skin and soft tissue infections that were MRSA and couldn't explain it. And there's some parallels with the findings here in this study, I think.
Yeah. Yeah, and I suppose with in these countries as well, with life expectancy and that, I suppose it's very hard to compare a certain age to, you know, a 20-year-old here versus a 20-year-old in Africa, and backgrounds maybe that they have as well. So yeah, again, I suppose some further information would be helpful in the study, but it is still very relevant and useful to have. And then we just have another comment about Fernando here, where the risk factors further stratified to identify. So were risk factors further stratified by wound type or cause, for example, surgical versus trauma wounds, to identify specific high-risk groups for targeted IPC interventions?
I think that's an excellent point. They weren't, to my knowledge, but I think that would be a really good way to kind of talk about where you can try and mitigate risk, or try and put your resource, your intervention appropriately, depending on where the risk factor is. So not to my knowledge in the paper, but I think that's a really good suggestion.
And then one last one here about clear guidance as well on how swabs need to be taken correctly, and ensuring there's no external contamination. I suppose this is something we all face when we get swabs, is it representative of what's actually in that wound? Is it something that's colonizing the surface as well? So something we face challenges with as well. I think possibly in the interest of time, just to ensure that we get to John's session and we answer his Q&A, and we can come back to any questions that we didn't get, if time permits, that we might let John speak now and discuss his paper.
Okay, thanks, Siobháin. Just noting the comment from a microbiologist in Egypt just at the end there around their local methods. Yes. So it's great to have a kind of international view on the methodologies that we're discussing today. Okay, can I just do a quick check that my co-panelists can see those slides okay?
Yes, John, all good.
Yeah, all good.
Great. I'm taking a risk and using a different way to share, though it's amazing that it's worked. Let's see if they advance. Okay, so we're gonna focus in on admission screening now for MRSA, and trying to look at the value of it based on a study that was undertaken in Malta. And to pick up on a point Phil's made already and Siobháin's referred to, MRSA, we don't talk about it as much as we used to. It's not as common as it once was in the UK, and it's much less frequent as a cause of serious infection. That being said, it is still around. I was involved in a review of a patient with an MRSA bacteremia recently, and it's still an organism that does cause serious infections. In other parts of the world, it's a very different scenario. We've heard about a study from Ethiopia with a really quite a high proportion of methicillin resistance amongst the Staph aureus in that study, and that's also true even in some parts of Europe. If I can just flick through to the next slide here, this chart is from EARSnet. Unfortunately, since the joys of Brexit, we can no longer put UK data on here for comparison, which is a big frustration because it's always good to have your kind of home country as the comparator. We can't do that anymore. If we were to do that, I think that the trend in the UK of the proportion of methicillin resistance amongst Staph aureus would probably look something like in France. I think at the worst of things, it was up in the 30-40% from memory, and nowadays it would be certainly below 20%, maybe even lower than that now. Although I haven't looked at the very latest data. But the point here is that that's not true in many other parts of Europe, where the proportion of MRSA amongst Staph aureus has remained really quite high. Greece, for example, is sticking around 40%. Malta is a different picture, where you can see up until 2017, it was one of the highest proportions in Europe, and that has since reduced quite dramatically, really, over the past 5 or 6 years. So that there's been a pretty amazing story to tell, and that's partially told by this paper. So the final point to make, just by way of preamble, is that there's considerable heterogeneity of practice when it comes to MRSA admission screening strategies, and that's within the NHS and within other parts of the world. Current operational guidance, at least my understanding of it, is that universal admission screening is no longer recommended as the cost-effective approach, given the prevalence in the UK of MRSA. That being said, many, perhaps even most organisations continue to do universal admission screening, and that's something that we'll come back to a little later on. So the study itself, it was undertaken in the Malta Hospital in Malta, which is a big hospital that essentially serves all of the healthcare needs, acute needs of the residents of Malta. I have visited the hospital once before, and it was a really lovely experience. The team there are fantastic, and the Maltese culture is just wonderful and warm and friendly and inviting. The study aimed to evaluate the impact of introducing universal admission screening from 2014 onwards, both in terms of the impact on MRSA prevalence and incidence and in terms of cost effectiveness. The cost effectiveness analysis was done by balancing the cost of the MRSA infections in terms of the quality adjusted life years against the cost of the intervention. So they didn't consider MRSA colonization in their cost effectiveness analysis. So it's likely to underestimate the true impact of MRSA. So this is what they've found. The proportion of MRSA positive screens through targeted screening was 12.5%, which fell to 5% by 2019 when they'd introduced the universal admission screening. Pretty excitingly, I think, the proportion of methicillin resistance in Staph aureus fell from 50% before the universal screening right down to 20% by 2019. They were able to run a statistical model. It's quite a big data model given the duration of the study, and it found that the intervention had a significant impact both on the incidence of MRSA and the proportion of Staph aureus resistant to methicillin. Good to see that the cost of the program against the impact in terms of qualities came up as cost effective. So the cost per quali was around €1,000, which is way below the kind of standard threshold of willingness to pay for a quali, where we often talk in terms of £30,000. So according to these methods, the intervention was very much on the side of cost effective. So I wonder what compliance with your MRSA screening program is in your institution. I bet it wouldn't be 98%, but in this study, that's exactly what they found. So 98% of the patients who they should have screened, they did screen. I think that the main reason for this is that the program was run and rolled out as an extension of the IPC team. So specific employees were brought on board who went around and personally swabbed all of the admissions. And I don't know how many admissions the hospital had, but it's a 1,000-bed hospital. So it wouldn't have been a small undertaking, and a remarkable model to sustain over that period of time. Very highly commendable. In terms of the strengths and limitations, the study was undertaken over a long period of time, and the authors make the case rightly that it's a strength because it allowed time for the intervention to slowly turn the tide on MRSA. If they'd have done the study after a 12-month intervention, the results would have been much less clear. On the other hand, though, because of the duration of the study over a decade or so, quite a lot of changes would have happened to the delivery of healthcare during this period, and that may have confounded any association that was identified. The study did include some data on common confounders, things like antibiotic consumption and alcohol gel consumption, which didn't change massively, and any changes I think were probably unlikely to influence MRSA particularly strongly, and the model did control for this. Perhaps the fundamental limitation of this kind of study design in terms of a sort of longitudinal before-after type approach is that it's uncontrolled. We don't know, we can't ever know what would have happened if the universal admission screening approach had not been implemented. Perhaps you could argue, you could look to Greece, as we saw earlier from the data, or other parts of Europe where the rate of MRSA has remained high. use that almost as a very fuzzy kind of control, but it's not as scientific as we'd like. So points for discussion. They noticed a reduction in the rate of positivity in their program for moving from a risk factor based approach to a universal screening approach. That's a bit of it's to be expected, because if you're screening patients based on specific risk factors for MRSA, you'd expect the proportion of positive to be higher than if you screen everybody for MRSA, which includes all the high and the low risk patients together. That said, there was certainly evidence that the intervention did reduce the incidence of MRSA and the prevalence of methicillin resistance amongst Staph aureus. What caused the spectacular reductions in the prevalence of MRSA in the UK, and does this study in Malta provide some evidence that actually universal admission screening and subsequent early identification and isolation was behind successes seen elsewhere in the world? A follow-on from this for me is, does universal admission screening continue to make sense in a low prevalence setting? We know that risk factor based screening is very difficult to implement on the front line. Universal screening is much easier to implement. There's no question or nuance around who gets screened. The process is everybody gets screened. And this study shows if you do that as an extension of the IPC team, you can get amazingly close to 100% compliance, which is nirvana, really. Is that kind of model something we should consider? I think during the pandemic, we had in some IPC teams some additional funding available, and there was an extension of the IPC team in some areas. So, for example, I was involved in developing what we called a PPE helper program during the pandemic, where some additional funds were used to bring some people effectively into the IPC team and create a program of improvement around PPE knowledge and usage. But that has its drawbacks, because then the IPC team becomes bigger, we have more staff to look after, and all the HR challenges that comes with along with a bigger team. And perhaps there's a risk of diversion of focus and resource away from some of the elements of the service that are perhaps more core to the infection risk across our hospitals. Interestingly, when we look at what was done in response to these to the screening program, MRSA patients were not routinely moved to single rooms, and yet control was achieved. There's a big argument at the moment around contact precautions for MRSA and VRE in particular, and whether they make sense. Does this argue that single room isolation for patients with known MRSA colonization is not necessary to control the spread of MRSA on an organizational level? That's certainly what these results suggest. Decolonization protocols were implemented, so perhaps there's an argument that decolonization of known positive MRSAs is more important than single room isolation. And that would be an interesting point to discuss. Be very interested to hear views of others on that point. So what does this mean for IPC? Well, I think it's probably time to have a look at your MRSA admission screening approach. Do you screen everybody? If you do, does that make sense in your local context and in your national context? If you don't screen everybody and you live in a high prevalence setting, perhaps on the basis of this study, it's time to look at that approach very carefully. So with that, Siobháin, back to you.
Great. Thank you so much, John. Another great paper then from the collection as well, and it was fantastic to see the downward trend for a change with the introduction of the universal screening. I suppose with the universal screening, and I know the most recent guidelines with JHI and IPS, suggest either a targeted approach or a universal approach, depending on your own hospital setting, obviously restraints and that on lab and cost. Is with the universal screening, is a lot of people admit it is really the cost and whether it's attainable, and whether in a low prevalence setting, whether we think this would add much, or are we likely capturing a lot of our patients with our targeted approach as well? Do you feel? Because I feel a lot of hospitals probably in Ireland, we have a targeted approach, expect similar in UK. And would you see any benefit in a lower prevalence setting of a universal approach?
Yes, definitely. There's huge benefits of a universal admission screening approach. One is that compliance picture is not out of the window, because you still have to take measures to ensure that the program is implemented properly. But a targeted admission screening for any organism is just a hard thing to do, because we have to get staff to think and ask risk factor based questions, and we know that's operationally difficult. There's also kind of an epidemiological completeness around a universal admission screening program. You really know what's going on and where your risks lie. I think looking back a few years, though, the MRSA now studies and others around that time showed us really that whilst universal admission screening is a nice approach and has benefits, it's probably not cost effective in a low prevalence setting. And I think it was something like anything below 2% of your admissions colonized with MRSA, that was the tipping point for universal admission screening. So I think probably in a low prevalence setting, targeted screening does make more sense.
No, it would be great if we had that data. And as I said, without the universal screening, we can't definitively say, you know, what prevalence we have, because we're targeting a high risk population. But then, as we spoke about in the last discussion, is often patients who are colonised with MRSA are people maybe we don't expect, the younger populations in the community as well. So having the universal screening is very helpful here, that we can actually definitively say that the prevalence has reduced over that period of time versus what we would see with a targeted approach.
Yeah, and I suppose if you are going to do a targeted approach, that's fine, but as you've alluded to, risk factors will change over time, and new clones will emerge, etc. And we had the whole emergence of community MRSA, as we talked about earlier. So I think if we do targeted screening, what is our assurance that it is still fit for purpose? How could we get that assurance? Is it through a national approach? Do we get national guidance that kind of gives us the insight on what's happening? Do we do local point prevalence screens of other populations that we're not screening in our targeted screening approach to give us that assurance? I don't know the answer to that.
Phil has his hands up, so he might, but I think he might have some questions to add as well.
No, it was another question really. There's a question from Vincent just talking about suppression therapy for people who are, you know, MRSA positive when they've been screened, and just wondered what your views were on that. And then also, John, like maybe building it and connecting it to the paper that I talked on. Do we need to worry about suppression therapy having an impact on AMR?
Yeah, good question. I think this study, the one from Malta, is really a lesson in the impact of decolonization and suppression therapy more than anything else. So it was effectively a targeted MRSA suppression intervention, and it seemed to show pretty good impact on this organizational level. I think impact on AMR will depend which agents you choose. If your decolonization or suppression approach includes mupirocin as an antibiotic, then I think there is some evidence that if we use too much mupirocin too broadly, we are likely to lose activity to that agent. There may be some other approaches using biocides for nasal. I'm going to say decolonization, probably suppression is a better word that we could look at, some chemicals and other approaches that may be coming down the line.
Thanks, John.
And one thing that's queried here as well, and people are always interested to know, is thankfully the study did show a reduction in the incidence of MRSA, but then did we see a comparable reduction in length of stay, morbidity, mortality? So were we able to directly correlate these to patient outcomes, and did we see a direct reduction in those as well, or was that covered in the study?
Yeah, I mean, this study was was quite nicely configured in that they had the kind of almost nested cost effectiveness analysis where they did measure the impact of the MRSA infections, not the MRSA colonizations, but MRSA infections, in terms of impact on the hospital stay, and also what wider impact when the patients left, and put that into a quality adjusted life years calculation. So this is one of the few studies of this design that actually has included that information as part of the methods, and that came out showing that the intervention, whilst in some ways costly in terms of the amount that it took to get it in place, was certainly cost effectiveness, or was certainly cost effective rather.
And there's a query as well, Colette, about whether we did manage actually to colonize these patients. If I'm correct, there was no follow-up swabs for these patients. Is that right? That if they were confirmed MRSA, they were offered decolonization treatment, and there was no subsequent follow-up of those particular patients. Is that right?
Yeah, that sounds right. That's my recollection. And I suppose you're assuming that there's a level of efficacy or sufficient efficacy to have an impact on a population level, even if on an individual level you may remain colonized, but perhaps it's the colonization is suppressed so that cross transmission is reduced, etc.
And Phil, I think you were going to.
Yeah, we've actually got the people in the webinar won't be able to see it because it's in the some of the comments in the Q&A, but Michael, the author of the paper, has just provided some context to some of the results. Loads of really helpful comments from Michael, but Michael in his last comment said MRSA is an indicator of system dysfunction, therefore centralising the intervention bypassed the dysfunction because everything depended on just us, as we highlight in the paper. And from a behaviour change perspective, centralisation, in my experience, is helpful in high prevalence settings. So it's a really interesting insight from Michael. I don't know if you want to comment on any of that, John.
Yeah, I mean, I love the idea of MRSA as an indicator of system failure, a bit of a canary in the mine, if you like, that something's going wrong in the process, and we'd completely normalized it. There were arguments, there was papers published to say MRSA is just a normal part of healthcare, and I think everyone got used to double figures of MRSA bacteremias for large organizations every month in the UK, and that's definitely not the picture we see anymore. As to exactly what's caused that change and that reduction, I think it's been multifactorial. I'm not sure we can pin it on universal admission screening and subsequent patient management. I think there are some other issues at play, but it is quite an impressive turnaround for sure.
And there's another question, John, from Catherine. Catherine says, always find it interesting that some patients we ask to actively swab. We ask staff to actively swab, and others we let patients swab themselves. The question is, did this occur in Malta to achieve the 90%, or was it purely done by the staff in terms of the screening?
I don't remember reading whether there was any patient-led swabbing as part of this, but they had the SWAT team who were employed to go out and swab patients for MRSA. That seemed to be their entire job. So I suspect that almost all of the time, unless there was the odd circumstance, that the extension of the IPC team that went to collect the samples did the sampling. I'm sure there is some data around the relative effectiveness of staff-led screening or patient-led screening for MRSA. Certainly for the resistant gram-neg organisms, I've been involved in some of this research, and there is, as you'd expect, a lower pickup rate with patient-led screening. But perhaps you play that off against the risk of not getting a swab at all, and having a slightly lower pickup rate is better than not having a swab at all.
And as you mentioned, John, rightly, is the compliance rate was completely so commendable. I don't think any hospitals are achieving that level of screening for their cohorts. I would wonder if the universal screening actually makes it somewhat easier to be compliant. With a lot of places having targeted screening and high risk, are some patients, is it easier to fall through the cracks and miss screening, rather than everyone is getting a screen so everyone's aware of it? And obviously in this setting they had people who were dedicated for that as well, but I wondered did that help the compliance rate as well with the screening, that it was for everyone, as opposed to a select cohort of patients.
Yeah, I've never really thought about that before, Siobháin, but I think that's quite interesting, isn't it? Because if you have a universal efficient screening policy, the messaging for the staff is more straightforward. You screen everyone. The messaging for the patients is also more straightforward. Everybody gets a screen. It's not that my bay mate next door gets a screen. Why don't I have one, or vice versa?
Yeah,
it's more straightforward for everyone.
Yeah,
that's true. Actually, is somebody being singled out because they were a contact of someone else, and requiring a screen for that purpose, or for previous admission elsewhere requiring a screen, but as you said, the person in the bed next to them doesn't. So whether that removes some of the, not stigma, but it removes some of that element that is just a universal policy, and we're not handpicking patients as such.
Yeah, I definitely think that plays into kind of the human approach, doesn't it? And what that patient experience is. Whereas if it's a kind of universal screening process, then it's kind of seen as something that is being done to everybody across the organisation. So it kind of maybe supports a kind of better understanding from the patients that it's just a requirement and it needs to be done for everybody, and they are not a special case. There's maybe one more question if we just have time. John, this is about whether or not you think that decolonisation to suppress MRSA is enough to reduce transmission in the healthcare setting, and do we need to think about other things like putting MRSA positive patients last on theatre lists to try and reduce transmission even further?
Yeah, I'm so pleased you asked me that. I saw it come through, and I wanted to raise it because I don't know whether MRSA decolonisation alone without single room isolation is enough to prevent the spread of MRSA. This paper is compelling, but I'm not convinced on the basis of this paper alone that it's the right strategy given the design of the study and the lack of control. In terms of this idea of putting MRSA patients and patients with other antibiotic-resistant bacteria last on the list, I really think we need to move away from that and get to a position where everybody in the organisation is aware of what they need to do when we have a patient with higher infection risk and implements those processes well and really effectively. I think there's a risk of stigmatizing patients and patients suffering with other aspects of their care if we start doing things like putting them last on the list, because which procedure is most likely to be cancelled? The one that's on the end of the list. So I think my main thrust is really, let's try and make sure that we're as a healthcare provider as a whole, not just IPC, encouraging people to manage infection risks as part of what they do.
Great. Thank you both for those excellent summaries today. I'm conscious that we're probably the people in between lunch for all the delegates on here today, and thank you again for joining us. Just want to mention here before Jon and Phil wrap up that while I have your attention, I'd just like to take a moment just to highlight the Healthcare Infection Society, not just as a valuable resource, and to share that we have HISCON again. I know I mentioned it at the start of the presentation as well, which is taking place next Tuesday and Wednesday. And those of you who are not members, I would highly recommend joining. For my fellow trainees, it is free, and it's an excellent resource with a wealth of benefits. So would highly recommend logging on there, and we've a QR code in the left-hand corner, and I think the guys are going to summarise and wrap up as well. So thank you very much.
Thanks, Siobháin. Just to, add to Siobháin's points about HIS, great organisation, and really looking forward to his conf for anybody on the call who's there next week. I don't think Jon and I decided who was going to do the what's next.
You're talking, Phil, so you do it.
Yeah. Thank you everybody for attending, and it's great to have the discussion. Thanks, Siobháin, so much for cheering. So just a quick outlook about our next couple of events. Our next Journal Club will be on the 2nd of July. Delighted to say that is in partnership with the Infection Prevention Society, and that's looking at making infection prevention live for frontcare healthcare workers. And then, sorry, we've got one before that. I've read them in the wrong order. The 18th of June is our next one. This is a sponsored journal club by Monlicki, and we will be looking at risk factors for post-operative Staph aureus infection, with Jon and I leading us through that. Just a reminder that you can see the schedule of all our journal clubs on our website, which is just ipcpartners.org, and all the recordings of our journal clubs are made available on our YouTube channel. So please do share with your teams, and maybe even use them for your own discussion within your organisations. We're also looking for guests, so if anybody's interested on being a guest within our journal club, we'd love to have you on. But finally, from IPC Partners, Jon and I, big thank you for the collaboration with HIS, and also a big thank you to Siobháin for chairing. We had a great time. Enjoy your lunch, everybody.
Thanks, everyone.
Thank you all.
Bye.